Hello, everyone. My name is Tyler Bollmeister. I am the current PGY2 infectious disease pharmacy resident at Moses Cone Hospital here in Greensboro. And the purpose of the following PowerPoints, this being the first, is to go through many different classes of antibiotics and teach you a little bit about each one. The first one here is going to be on beta-lactams, and the slides are courtesy of Emily Sinclair, who is one of our infectious disease pharmacists at Moses Cone. So there are many drugs in the beta-lactam class alone, and the best way to keep them straight is to go through them in each individual class and learn characteristics of each. So the classes include penicillins, cephalosporins, carbapenems, and monobactams. And the main monobactam that we'll talk about today is aztreonam. They work by inhibiting the penicillin binding protein transpeptidases, which in turn causes cell lysis and death. Now, this mechanism gives all the classes something in common, which is that they lack atypical coverage, and that is because atypical organisms lack a cell wall, so it makes sense that these classes wouldn't be affected in that case. Their spectrum of activity includes gram-positive as well as gram-negative organisms, and the scope of this varies widely between each class and generation, which we will get into a little bit more as we dive into each class. So first up, we have our natural penicillins, which includes penicillin G and penicillin V. Penicillin G is available only in the IV and IM formulations, and it's dosed in millions of units, while penicillin V can be taken by mouth and is dosed in milligrams. That's something to remember or to help you recognize the difference between the two. Penicillins have great strep coverage, but they do also cover some other bugs really well, such as Treponema pallidum, better known for causing syphilis, and Neisseria meningitis. It has variable activity to strep pneumo and enterococcus, meaning they should not be used empirically if these organisms are suspected. And as far as staph coverage goes, it's hardly ever effective because staph quickly developed resistance to these penicillins. Some of its clinical uses are things such as strep pharyngitis, syphilis, and meningitis caused by Neisseria. So unlike the previous group of penicillins, this group of anti-staphylococcal penicillins is known for its ability to cover staph very well. And the reason that this class is able to cover staph very well in comparison to the other is because it has the ability to protect itself against penicillinases. And it's also important to realize these medications cover methicillin-susceptible Staph aureus, not methicillin-resistant Staph aureus, also known as MRSA. Dicloxacillin is the only available PO version of this class of penicillins, but it's not available in the US, so you won't be seeing it. Nafcillin and oxacillin can be used interchangeably depending on your hospital's formulary, and they work very well for invasive MSSA infections, including central nervous system infections, and the reason for that is because they penetrate the blood-brain barrier very well. Some potential side effects to be aware of with these drugs is they do contain a lot of sodium, which can lead to hypernatremia or exacerbate heart failure in patients who have that. And although they don't require a renal dose adjustment for poor renal function, they can cause acute interstitial nephritis, which can result in a decline in kidney function. Then we have our aminopenicillins, which include ampicillin and amoxicillin. Ampicillin is available in IV, IM, and PO, but we don't really use it PO because of its reduced bioavailability and significantly more GI side effects when compared to amoxicillin. These two drugs cover strep and enterococcus very well, but they do not have activity against Staph aureus. They also have some gram-negative coverage, including Haemophilus influenzae, Proteus, and E. coli. What is important to remember, Haemophilus influenzae and E. coli can produce penicillinases, which can give them resistance to these drugs. Because of this coverage, it is the drug of choice for conditions such as otitis media, strep pharyngitis, and AMP-sensitive enterococcus infections. Next, we have our aminopenicillin and beta-lactamase inhibitor combinations. So we can see that amoxicillin is paired with its beta-lactamase inhibitor, clavulanate, and ampicillin is combined with a different beta-lactamase inhibitor, sulbactam. These beta-lactamase inhibitors don't have antimicrobial activity themselves, they just free up the beta-lactam to kill the organism. By inhibiting these beta-lactamases, it gives these drugs activity against methicillin-sensitive Staph aureus, more gram-negatives like Klebsiella, and also anaerobes. Because they have anaerobic coverage, these are great options for people with intra-abdominal infections, aspiration pneumonia, and wound infections, which is when we would be concerned about anaerobes potentially being present. And the last class of penicillins is the extended spectrum penicillins. This class is very similar to the last slide with the addition of Pseudomonas coverage. The main agent of this class is piperacillin tazobactam, also known as Zosyn, and this should only be used for as a very broad spectrum agent when there is concern for Pseudomonas infection. Now, moving on from the penicillins to the cephalosporins, there are a lot of different cephalosporins available, and they can be very confusing, very overwhelming. But eventually, with some practice, as you become a little bit more familiar, you'll be able to identify which agents make sense to use and for what indications. So first up, we have our first generation cephalosporins, and the drugs to remember in this class are cephalexin, which is administered by mouth, and cefazolin, which is administered intravenously. These medications have great activity against methicillin-sensitive Staph aureus and Streptococcus. They also have some gram-negative coverage, including Proteus, E. coli, and Klebsiella. However, these, just like all the generations of cephalosporins, have no Enterococcus coverage, which is something important to remember about this class of medications. Some important differences to note when comparing the anti-staphylococcal penicillins, such as oxacillin or nafcillin, to these first generation cephalosporins such as cefazolin is cefazolin has much more convenient dosing. It is dosed 3 times a day, whereas nafcillin can be dosed up to 6 times a day. A drawback of cefazolin compared to nafcillin is it does not cross the blood-brain barrier like nafcillin does. And a common misconception is these drugs cannot be used in penicillin allergic patients, but actually they can the majority of the time as long as the allergic reaction is not anaphylaxis. And the reason for this is research has found that actually the cross-reactivity between cephalosporins and penicillins is actually less than 2%. So with all that said, some of the clinical uses and where you'll see these drugs are in invasive MSSA infections, some skin and soft tissue infections, UTIs, and surgical prophylaxis. Next up, we have our second generation cephalosporins, which have less activity against gram-positives, but more activity against gram-negatives when compared to the first generation cephalosporins. And some of these differences are second generations cover strep pneumonia well, E. coli, and Haemophilus influenzae. And because of this, they are typically used for upper and lower respiratory tract infections. And something else interesting about this class is they actually have 2 cephalosporins that have anaerobic coverage, and these drugs are cefoxitin and cefotetan. Following the same trend, the third generation cephalosporins have less gram-positive and more gram-negative coverage compared to the first 2 generations. But this class can be tricky because not all third generation cephalosporins are created equal. And an example of what I mean is a third generation cephalosporin ceftazidime actually has Pseudomonas coverage, but it is not to be used for gram-positive infections because it does not have gram-positive coverage. Clinically, we typically use these empirically for infections such as UTIs, pyelonephritis, lower respiratory tract infections, and sometimes skin and soft tissue infections. There's only one fourth generation cephalosporin to remember, and that is cefepime. And the main things to know are that it covers a broad range of gram-positives, including staph and strep, as well as gram-negatives, most notably Pseudomonas. So clinically, this is a very broad spectrum agent that should only be used when we're concerned for infections such as Pseudomonas. There's also only one 5th generation cephalosporin to know, and that is ceftaroline. This is a relatively new and expensive medication that is generally reserved as a backup after treatment failures. The most notable thing about this drug is that it covers MRSA. It is the only cephalosporin that covers MRSA. You can think of its coverage similar to the third generation cephalosporin ceftriaxone, except that this one has MRSA coverage. Clinically, you will see it used in infections such as skin and soft tissue infections, pneumonia, and endocarditis. Next, we'll move on to a different class of medications called the carbapenems. The carbapenems have some of the broadest spectrum of action. Some things that they all have in common is that they do not cover MRSA or atypicals. However, not all carbapenems are created equally similar to the third generation cephalosporins. And it's ertapenem that has some of the gaps in coverage when compared to the others. So ertapenem does not have activity against Pseudomonas, Enterococcus, or Acinetobacter. However, the advantage of ertapenem is that it is able to be dosed once daily. Imipenem and meropenem are similar in that they do cover Pseudomonas, Enterococcus, and Acinetobacter, as well as many other gram-positive and gram-negative organisms. These drugs are fairly well tolerated. They do have good CNS penetration, and because of this good CNS penetration, they have been known to cause seizures, and imipenem carries the highest risk for this. The biggest takeaway from this class is that it is among one of the broadest empiric agents that should be reserved for use in patients who are at risk for multi-drug resistant organisms. The last class of beta-lactams that we'll talk about are the monobactams, and aztreonam is the drug to know in this class. Aztreonam only has activity against gram-negative organisms, but that does include Pseudomonas. It is most typically seen being used in penicillin-allergic patients as kind of an alternative to Zosyn, which is piperacillin tazobactam, plus an agent that covers gram-positives broadly, such as vancomycin. It is a very expensive agent, and clinically it should be reserved for those who cannot tolerate other agents that have similar coverage, or when there's no other alternative available. So overall, beta-lactams are generally well tolerated, but there are some adverse events that can come along with their use, most typically GI intolerance, hypersensitivity reactions, and the risk of seizures. But that, again, as I mentioned, is most common in carbapenems. Another very common thing to encounter in practice are patients who have a penicillin allergy. And about 90% of patients with a penicillin allergy do not have a true allergic reaction when given an immunologic challenge. A detailed history is required to determine the nature of the penicillin allergy and the risk of exposure to other beta-lactams. And there are many ways to reconcile patients' allergies based on their history, such as a penicillin skin test or a direct oral challenge, and these things may or may not be available at your institution. And as you can see, as I mentioned earlier as well, the cross-reactivity of penicillin to the other beta-lactam classes, such as the carbapenems, cephalosporins, and monobactams, is no more than 2%. There are many different types of allergic reactions, but the two we will touch on briefly today are type 1 and type 4. Type 1 reactions are generally the most concerning because they include anaphylactic reactions. And these type 1 reactions typically occur within minutes to hours after a patient has taken the offending agent. And patients who do have a true anaphylactic reaction will need to avoid beta-lactams for the most part, excluding aztreonam until their allergy can be further evaluated. Your type 4 reactions tend to be more delayed, anywhere from days to weeks before they onset, and they generally manifest as a maculopapular or morbilliform rash. However, they are generally much less severe than type 1 reactions, but that's not to say that they can't manifest into serious reactions. Some examples of serious reactions that are type 4 would be things such as Stevens-Johnson syndrome or DRESS. So the most important thing to remember with patients who have penicillin allergies is getting a patient history is extremely important. Oftentimes, patients' reactions or allergies are misrepresented in the chart, so asking them questions like, what drug did you take that caused the reaction? What was the reaction? When did the reaction happen? Have you tried to take that drug again or drugs that are similar to that drug since the reaction? So all of these can be very helpful to determine the legitimacy of an allergy and what the appropriate next step should be. Lastly, I have a case. So we have a 15-year-old female who presents to the clinic with a chief complaint of sore throat and fever. As you can see, her vitals, she has a Tmax of 100.5. She weighs 50 kilograms. On physical exam, everything is negative except redness of the tonsils. And you see that she does have an allergy to penicillin listed, reportedly when she was 4 years old, as itching. So the question is, what do we give her? So first, we need to diagnose her before we can decide on treatment. So her symptoms are very consistent with strep throat. So one of the things that we could do is the rapid strep test and culture to determine if that's what she has. And for the sake of the case, we will say that she's positive for strep throat. The next step is to remember what agents have good strep coverage. So we know penicillin has excellent strep coverage, and the VK formulation is by mouth, so we might consider that. But she does have a penicillin allergy listed, so let's see what other options there are. Next, we have piperacillin tazobactam, which is part of our extended spectrum beta-lactamase inhibitor class, which definitely would cover strep, but it is IV, and it is much too broad for this patient case. We should be able to use a much more narrow therapy. And cefdinir is an oral third-generation cephalosporin that does have good strep coverage, and we know that cephalosporins have a low rate of cross-reactivity to penicillins, less than 2%. And especially since ceftonir is a third-generation cephalosporin, which is even less concerning as far as cross-reactivity than first and second-generation cephalosporins. And lastly, we have ertapenem, which is an IV carbapenem. We would like to use an oral option, as hopefully she's an outpatient. And again, its coverage is too broad, just like piperacillin and tazobactam, so we should try to pick a more narrow agent than that. So now we've ruled it down to either A or C, and for the sake of the case, we'll say that we clarified the patient's penicillin allergy, and it is a real allergy. So instead of challenging this patient with a penicillin again, we should go with option C as ceftonir, as this is a good option in penicillin allergic patients, and it will cover the strep very well. And as we can see, ceftonir is the correct answer for this patient. So at this time, I want to thank you all for listening, and I hope this information was helpful.